Hello everybody. Welcome to the third of my series of lectures on developing imaging biomarkers. You will remember that in the first lecture we had an illustrative introduction to biomarkers. In the second lecture we discussed the regulatory view on the development of biomarkers. And in this third and final lecture, we will talk about the steps needed to build the clinical value of biomarkers so they can be adopted into the clinic. So to begin, let's start with a brief summary. We said that there were four major types of biomarkers: diagnostic, prognostic, and predictive biomarkers. We said that prognostic biomarkers inform on the future outcome of a cancer patient, and prognostic biomarkers are therefore used to identify men with a very favorable or a very unfavorable outcome where dose escalations provide no added benefits. So prognostic biomarkers are used when new therapy approaches are needed. On the other hand, predictive biomarkers inform on the likelihood of a benefit or disbenefit to a specific type of therapy, and are used when there are multiple therapy options and outcomes need improving. In the second lecture, we discussed the regulatory view, the biomarker type, its context of use, and the risk to the patient determines the level of evidence needed to support a biomarker qualification. Higher levels of evidence are needed for more meaningful biomarkers for more serious health conditions in a risk-based approach. So for diagnostic biomarkers, there is no regulatory requirement to show management or outcomes impacts. If these are shown, then the clinical value of the biomarker is increased, but it is not a requirement. A prognostic biomarker is primarily used to risk stratify patients, and it may therefore affect their management with secondary impacts on quality and the quantity of life. Predictive biomarkers should be evaluated as therapeutics, focusing primarily on the quantity and quality of life. However, there has been much pushback from clinicians, all of them saying that the value of an imaging biomarker comes when it is shown that the biomarker helps maximize treatment benefits, minimizes undertreatments, reduces or prevents overtreatments while tempering costs and toxicities. In other words, if we are going to build value to a biomarker, we need to go beyond just diagnostic accuracy, efficacy. We do need to think about thinking efficacy, therapeutic efficacy, and patient outcomes efficacy. So how do we build clinical value in real life? Essentially, there are 6 steps that we need to consider. I've just outlined them here, but we will go through them one by one. The first one is to define uses where management changes are possible from the imaging result. Number 2, we have to ensure that biomarkers are independently diagnostic or prognostic when incorporated into multivariable clinical models. Number 3, we have to ensure that the biomarkers improve the discrimination for clinically meaningful endpoints. Number 4, we have to estimate both the absolute and the relative benefits of the application of the biomarker. All of this has to be done in high quality of evidence studies. Finally, we have to demonstrate that the test is useful because it causes changes in management with or without survival changes. Okay, let's take each of these in turn, but we will look at them with specific examples that you have already seen and with examples of imaging biomarkers that you have not yet seen. So the first condition is the use in settings where changes in management is possible from the imaging result. What imaging biomarker would you need to reduce overdiagnosis of indolent cancers? We already discussed that we would use the PI-RADS score on an MRI because it is a diagnostic biomarker. What biomarker would you use for intermediate risk disease to select favorable and unfavorable subgroups for initial active surveillance? This again was a diagnostic biomarker, and the biomarker we said was the visibility or the invisibility of a lesion. What type of biomarker would you need for patients with low-risk disease to decide whether you continue active surveillance or to start active management now? Here we said we needed a prognostic biomarker because it predicts a future clinical event, and we said that the MRI precise score would be a suitable prognostic biomarker. What sort of biomarker would you need to decide which man with metastatic hormone-sensitive prostate cancer should have additional pelvic radiotherapy? Here we said we needed a predictive biomarker because the number of bone scan lesions in a man with metastatic hormone-sensitive prostate cancer predicts for who will benefit from an overall survival advantage perspective. As a final example, what sort of biomarker do you need to select men for metastasis-directed therapies? This turns out to be a diagnostic biomarker where if you have less than 3 to 5 lesions on a PSMA PET-CT scan, you have a survival advantage with metastasis-directed therapies. So condition 1 is used where imaging in management is possible from the use of the imaging result. Condition 2 was ensure that the biomarker is independently diagnostic and prognostic when incorporated into multivariable models. So if we break this down, you can see that the biomarker has to enhance discrimination when combined with traditional biomarkers, including existing multivariable models. We saw this example previously, where the extent of disease on a morphological MRI was shown to be prognostic for apparently localized prostate cancer undergoing radical radiotherapy. The presence of no disease visible meant that the prostate cancer-free specific survival was almost 100% at 15 years. If you had disease within the extraprostatic space or within the seminal vesicles, you had a much worse prognosis. Now it turns out that when this finding was added to traditional models, that it was additive. So here is the EAU risk categorization, here is the MRI categorization, which is over here, and when you add them together, you enhance the discrimination. So this is what is meant when we say that the biomarker is independent of traditional factors and it enhances discrimination when combined with traditional factors, including multivariable risk models. Condition 3. We have to ensure that biomarkers improve discrimination for clinically meaningful endpoints. Here there are two things we need to note. One is that this is a consistently improved discrimination, and two, the biomarker is appropriate and meaningful. So in the context of a diagnostic biomarker, it's, say, cancer detection. Let's take the example of combining the PI-RADS score and PSA density. Now we know that PI-RADS score is a imaging biomarker. We've already discussed this. The PSA density is also a biomarker, and combining the two is also a biomarker. Remember, when we discussed biomarkers in the introduction, we said it could be one feature or a set of features, and in this particular instance we are combining the PI-RADS score with the PSA density in ranges, and trying to predict which patients have a higher or lower likelihood of clinically significant disease. And in this example, you'll see that if you have a PI-RADS 1 and 2, provided you have a low PSA density, you have a lower risk of clinically significant disease. If you have a higher PI-RADS score with a higher PSA density, you have a higher risk of clinically significant disease. So how consistent is this finding? Well, this was evaluated in this paper, where 4 studies in the literature were taken, where you can see the PSA density is given over here, and the PI-RADS scores are given here, with each study shown as a row. You can see that in 4 studies combining over 2,000 patients, you can see that a lower PI-RADS score with a lower PSA density consistently shows a lower prevalence of clinically significant disease. A higher PI-RADS score with higher PSA density consistently shows a higher likelihood of clinically significant disease. So I've shown you 5 studies now showing consistency. It is appropriate because we're looking at clinically significant disease defined as grade group 2 or above, and it's meaningful because it can be used for biopsy planning. Condition 4. For diagnostic and prognostic biomarkers, estimate both the relative and the absolute benefits of the biomarker application. So for diagnostic biomarkers, that means that you have to estimate both the AUC values from ROC curves as well as the rule in and rule out abilities. So let me just show you an example. So this is the IMRI study, which was a retrospective multicenter study looking at 10 sites with over 2,600 patients. In this study, you can see that the prevalence of clinically significant disease was 43%. On the left-hand side, you can see what is meant by the rule in and rule out ability. Rule in is positive predictive value and specificity. Rule out is sensitivity and negative predictive value. So here you can see that if you applied PI-RADS 1 and 2 as being a negative test, then the sensitivity for ruling out disease would be about 87%, but if you added that to the PSA density, then that improves by about 10%. Similarly, you see an improvement in the negative predictive value by about 3%. And by doing a sensitivity analysis, you can see how the negative predictive value improves from 82% if you use PI-RADS 1 to 3 to denote negative disease to 86% if you used PSA density and the PI-RADS 1 to 3 score. On the right hand side, you can see the AUC values for the different methods of evaluation. So if you use the PSA alone, the AUC value will be 0.56, and you can see how that improves by using PSA density, and improves even further once you use MRI score, but you can see how the discrimination improves even further by combining MRI and PSA density. Remember that AUC values from ROC curves and rule in and rule out statistics, sensitivity, negative predictive value, specificity, positive predictive value, are relative terms, but you also need to work out what the absolute benefits of the biomarker are. In other words, you need to estimate the absolute number of cases that will be detected or missed compared to a standard approach using clinically appropriate thresholds. What is meant by a clinically appropriate threshold? This graphic illustrates what I mean. So at the top on the left-hand side, you can see men at risk for clinically significant cancers undergoing a prostate MRI PI-RADS negative, intermediate, and positive, and based on their MRI, their history, their PSA density, and other biomarkers, you can estimate the likely risk of prostate cancer. Generally speaking, these factors alone will tell you who needs a biopsy. So if you have a low clinical likelihood of clinically significant disease, you would be considered as being at low risk, and you could probably avoid a biopsy going on to follow up with a safety net protocol. If you have intermediate or high risk of prostate cancer, then you would usually undergo an MRI targeted biopsy to the lesions that have been identified, plus or minus a systematic biopsy. However, we also have to take into account preference thresholds according to the patient groups. What do I mean by this? Well, there are patients who are cancer averse. So these are patients who have had a previous negative biopsy and their PSAs continue to rise, or patients who have had a previous MRI that was negative and their PSA continues to rise. So in these patients, the diagnostic aims are to detect clinically significant cancers. These patients are less concerned about false positive results, and a typical threshold for them might be 5%. In other words, this group. On the other hand, there are patients who are biopsy averse. These are patients who have a low prevalence of clinically significant disease, such as in the screening setting. For these men, it's important to avoid a biopsy and minimize overdiagnosis. For these men, you may want to consider a much higher risk for biopsy. In other words, these men. So not only do we have to take into account MRI, the history, PSA density, and other biomarkers, but we also have to take into account patient preferences. So coming back to this data, we have shown that the combination of PI-RADS scores and PSA density consistently improves the depiction of clinically significant cancers, leading to meaningful results for biopsy planning. How do we estimate the absolute numbers of cases detected and missed compared to a standard approach at clinically applicable thresholds? Well, if you combine the data together, you end up with this matrix table showing you the PI-RADS scores here and the PSA densities over here, and within each of these squares we can estimate the number of patients within each square that would have clinically significant cancers. So if you take this compilation and you apply the preference threshold of 10%, which is the EAU risk threshold, we can show that compared to the standard approach, the number of biopsies avoided is 38%, the number of clinically significant cancers detected is 95%. In other words, you will miss 5% of cancers. If you were to apply a lower threshold, remember these are cancer-averse patients, such as persistent suspicion after a prior negative biopsy or a prior negative MRI, then you would biopsy all of these patients in red, and if you did that, you would avoid 22% of biopsies, but you would detect 99% of the cancers that are there. On the other hand, if you were biopsy averse, and I said this was in the screening setting at a lower prevalence, here you might prefer a much higher preference threshold, say 20%, then you would avoid 45% of biopsies while still detecting 92% of the cancers that are there. And this is how you estimate the absolute number of cases detected and missed compared to a standard approach using clinically applicable thresholds. Condition 5 refers to assessing performance on clinical decision-making and management using applicable endpoints. And this is divided into a number of areas which we will now consider in turn. So diagnostic biomarkers should be evaluated for diagnosis decision impacts at clinically applicable thresholds. Many of you will not be familiar with decision curve analysis, where we plot the net benefit, which is the cancer detection, versus the patient preference or the probability of cancer on the x-axis. Many of you will not be familiar with interpreting decision curve analysis, and this paper by Andrew Vickers is highly recommended. Essentially, you plot the net benefit versus the threshold probability or the risk threshold on the x-axis. If you had a perfect test with 100% sensitivity and 100% specificity, the curve would look like this. If the test was 99% sensitive and 99% specific, then the curve would look like this. In other words, the higher the curve along the net benefit axis, the greater is the sensitivity. The flatter the curve, the greater is the specificity. So typically, a trust biopsy is about 50% sensitive and about 99% specific. So here is the data from the PROMISE data. You can see the sensitivity is 50% and the specificity is 90%. So the sensitivity means that it's detecting about half the cancers that are there, so about half of the cancers that are there, but it is very specific, so you expect it to be nice and flat. So there we go. That's what the trust biopsy curve would look like. And an MRI is about 90% sensitive and about 45% specific, so it'll reach higher on this x-axis, but it'll have a steeper gradient. So an MRI will be about 90% sensitive and about 50% specific, and you can see that that's the expected curve. Now remember, we are trying to biopsy patients who have typically between 5 and about a 30% chance of having prostate cancer. So at a threshold probability of 5%, we would expect the MRI to have a better performance than a trust biopsy, but there will be a cutoff point at which the performance of an MRI and a trust biopsy will be identical. So let's look at biopsy decision making using decision curve analysis. These are cancer detection rates and the predictive values of MRI score according to PSA density groups. You can see that the higher the PSA density, the greater is the probability of clinically significant cancers. The higher is the likelihood of clinically significant disease on the MRI, the greater is the probability of clinically significant cancers. And you can see there is added value of adding the MRI score with the PSA density, as we have seen previously. The decision curves are shown here on the left-hand side, with biopsying nobody here and biopsying everybody shown here in red. Remember that we're interested in the best decisions for men who have approximately 5% to about 20 to 30% chance of clinically significant cancers. And looking at this curve carefully, we can see that these strategies here outperform these other strategies on the decision curve analysis. So let's look at these in more detail. So the simplest decision is PI-RADS 3 to 5. If you just biopsied all patients with PI-RADS 3 to 5, you would avoid about 19% of biopsies, but you would only miss about 3% of clinically significant cancers. If you decided to biopsy PI-RADS 4 and 5, or anybody with a PSA density of greater than 0.2, then you can see that the biopsies avoided will be 39%, so marked improvement, but you'll see that the number of cancers that you miss is almost 10%. All other PSA density-dependent strategies are about the same. So for strategy 1, we said it's 39%. For strategy 7, it's 41%. For strategy 8, you can see it's 38%. And all of them miss about 10% of clinically significant cancers. So this is how you can use decision curves to decide on the best strategy to use to maximize the benefits, which are avoiding a biopsy, minimizing the detection of clinically significant disease, while not compromising on the number of clinically significant cancers that are missed. Sticking to the theme of clinical trials, the next most important thing to do is to make sure that prognostic biomarker development takes into account time biases. What are these time biases? Well, we know that diagnostic and prognostic biomarkers improve lesion characterization, in other words, false positive versus true positive distinctions, improves detection, often of both indolent and aggressive disease, and improves risk stratification. By doing this, it actually introduces time biases. There are three types of time biases that we need to be aware of: the Will-Rogers effect and lead and length time biases. So let's start with the Will-Rogers effect. Now let's imagine we're doing a systematic biopsy in a population of patients with suspected of having prostate cancer. Eventually, after doing a systematic biopsy, you will have people who have disease and people who don't have disease. And if these people are treated and these people are not treated, then over time we would expect the cancer patients to have a higher biochemical recurrence rate compared to the patients who have no cancer, who will have a lower proportion of patients who develop biochemical recurrence over time. And this is because of underdiagnosis that occurs in the non-disease group. Now, if you did an MRI, and for a negative MRI you did a systematic biopsy, and for a positive MRI you did a systematic plus an MRI targeted biopsies, then the disease and no disease groups would look something like this. So you can see that you would get reclassification due to improved sensitivity. In other words, these patients here with cancers would end up over here. Now what you have to remember is that in the detection focus pathway, if you do a systematic and an MRI targeted biopsy, for every additional man with clinically significant disease that comes over here, a man with indolent disease will also come over here. So these will be the proportion of patients. So there will be an increased prevalence of patients with disease. Now, if you were to use the same treatment as you would have done originally, then what you find is that the biochemical recurrence rates in both groups improves. So in the no cancer patients, you can see there is a lower rate of biochemical recurrence because this group is now purer. This group also improves, and this group improves because of the dilution effect of indolent disease within this group. You also have to remember that survival also improves because of the earlier detection and treatment of clinically significant disease, and this is called lead time bias. Also, there's an overdiagnosis and an overtreatment of indolent disease. So they also contribute to improved survival of the whole group. So to summarize, MRI introduces survival biases by both the detection of important and unimportant disease if the biopsy strategy is not adjusted. The Will-Rogers bias is improved subgroup survivals due to reclassification of undetected disease, remember, of both important and unimportant disease. Lead time bias is an overestimation of survival duration due to the earlier detection of clinically significant disease if the earlier institution of therapy has no benefits. And length time bias is the overestimation of survival duration due to the overdiagnosis and the overtreatment of good prognosis disease. Sticking to the theme of clinical trials, trials of diagnostic or prognostic biomarkers should assess changes in the diagnosis and therapy management, respectively. So here's an example where MRI was shown to have value compared to systematic biopsies for prostate cancer diagnosis. So on the left-hand side, you can see systematic biopsy, and on the right-hand side, you can see the MRI pathway. And remember, the MRI pathway is negative MRIs get no biopsies, positive MRIs get an MR-targeted biopsy alone. Adopting this strategy, you can see that the MRI value comes in the fact that 33% of men can avoid a biopsy, and there is a decreased prevalence of insignificant disease while not impairing the detection of clinically significant disease. Here is another example of a management impact of a diagnostic biomarker. We have seen in a previous lecture the Osprey study, which showed that PSMA PET-CT scans had a greater detection sensitivity compared to conventional imaging. And we find the same is true in the PRO-PSMA study, which was performed in unfavorable intermediate risk prostate cancer and high risk localized prostate cancer before curative intent surgery or radiotherapy. But what you also notice that there is a greater therapy impact of PSMA PET-CT. So PSMA PET-CT change a management strategy in 28% of cases, whereas conventional imaging changed the therapeutic strategy in 15% of cases. The sensitivity result is almost identical in the Osprey study when we were discussing the regulatory requirement for a diagnostic biomarker. Remember that from a regulator's perspective, the primary role of a diagnostic and a prognostic biomarker are to improve diagnosis and risk stratification of diagnosed patients to enable therapeutic decisions to be made. The latter may impact secondarily on survival and quality of life endpoints. However, from a clinical value perspective, value comes when it is shown that the biomarker maximizes treatment benefits, minimizes undertreatments, reduces or prevents overtreatments while tempering costs and toxicities. In other words, clinical value is when there are positive diagnostic thinking impacts, therapy impacts, and positive patient outcomes impacts, hopefully with societal benefits. Finally, we need to talk about trials of predictive biomarkers. Now, predictive biomarkers should be evaluated as therapeutic studies focusing on quality and quantity of life. One of the biomarkers that we discussed originally was the presence of PSMA-avid disease to predict for the likelihood of benefit to an anti-PSMA directed therapy. And here is an example of a man who has a negative FDG PET scan, has a positive PSMA PET-CT scan, and you can see he's had a dramatic response to lutetium PSMA therapy. And that biomarker was used to select patients for anti-PSMA directed therapy, and you can see how lutetium PSMA resulted in a better survival than the standard of care, and this data has now been submitted to the FDA for licensing approval. So here are my take-home messages for this last lecture. Building clinical value of an imaging biomarker is a multi-step process that goes well beyond the needs of a regulatory approval. Imaging biomarkers of clinical value should better detect, better predict, better prognosticate, and enhance treatment decisions. But the primary role of a diagnostic and a prognostic biomarker are to improve diagnosis and risk stratification so that management decisions can be made. These management decisions may affect survival and quality of life endpoints, but secondarily. And that's the real important thing to remember. I hope that you have found each of these lectures useful. the introduction, the regulatory view, and the more detailed clinical development view. Leave me some comments. Thank you very much for listening.